That's what I need you to know. This is a water issue, not a salt issue. And then, of course, the last three. Did you notice it? All organ failures. Liver failure, kidney failure, heart failure. I hope you're rolling with your girl, not asleep yet. Okay? Now, risk factors. Oh, for sure, the elderly. The elderly are at huge, huge risk. Climate. We had several patients with SIADH, this kind, the fluid volume deficit from dehydration in Katrina. Oh, you forgot about Katrina, you know, the biggest hurricane in the history of America and the biggest nightmare for patients. Oh yeah, where was that? It was in New Orleans. Do you know the average temp? Oh, just right around 99 to 105 every single day of the summer. And Katrina happened in the summer. So climate, hot environments, and we do know there's a such thing as global warming. If you're confused or you're politically retarded, let me help you with this. The snow and the cold that I had as a child growing up, I haven't seen it at all in the last 5 years. Okay, just being real with you. We got snow days all the time. We had snow up our butt. I mean, it was like 2 feet of snow, and that was normal. You trudged through it, you went your butt to school. You don't even get that. You get 4 inches, they're shutting down everything now. Okay, so climate matters. It's getting hotter, people. You got hurricanes, and they're devastating. Just ask Puerto Rico. Okay? Now, so if you look at the rest of these, certain medications, we said the diuretics, complications, OMG. All you need to know for this one is seizures and high ICP. If you keep on going, there is completely irrelevant crap on this handout, but it's there just because it's part of the handout and it's part of you flowing to the next page. But on the last page, it talks about treatment. So do me a favor. It starts down here, but you care about up here. Treatment, intravenous fluids. What kind of fluids? Sodium, salt water basically, okay? Like 3% salt water. And then you see medications. And here I would write the word, and I'll write it on the board for you. I would write mannitol, because it's going to make sure that your ICP goes down and prevent the cerebral edema. Okay? Hormone therapy, you don't really care. You really don't. Okay? Now, I got to tell you, if you turn the page, you should see a page that says, ta-da, heat exhaustion. Turn it again, and it actually says heat stroke. I don't care that you go crazy here. It is on the Oh My God packet. What I want you to focus on here are these 2 words. Stroke is a neuro issue. It always has to do with your brain not functioning well. So there is no such thing as a heat stroke unless your patient's confused and out of it, okay? So that's the first thing at the top. Anxiety, confusion. What's the skin of the patient, hot and dry? Can they sweat? Absolutely not. What do they have? Highlight it and call it hyponatremia. I need you to know this. So look, stroke, right? Go over here. More stuff. Confusion, delirium, seizures, blah, blah, blah. You already know this. If I don't have any volume, fluid volume in my body, because this is dehydration, if I don't have any fluid volume in my body, then I am going to be hypotensive. I hope you understand what I'm saying, because look, in this case, and please write it on this page, in this case, the heat stroke patient is hyponatremia due to a fluid volume deficit. They are losing salt when they sweated it all out with the water, and you will have the opposite signs and symptoms: low blood pressure, dizziness, all these symptoms with fluid volume deficit, that's what you're going to have. And so here we go. What's the cause? Well, diuretics, burns, sweating, GI, NPO, adrenal insufficiency. But in this case, we're just talking about plain old-fashioned heat stroke. The warning signs, of course, if you care to catch it early, is heat exhaustion. There is a difference. This patient with heat exhaustion is still able to sweat. Their skin is moist, okay? Now, of course, we cool both of these patients off with ice packs in the groin and the axillary areas, and that's just how we cool them off. We put a cooling blanket on them. We do all of those things, all right? Now, let's move on to another electrolyte. It's a fun electrolyte because it's not that hard. I want you to go backwards in your packet because it's really easy. And I want you to go to these kids playing on the teeter-totter or the seesaw. It is after spironolactone. Yeah, I said it, spironolactone. It's after that, okay? It's the next page. Here we go. When it comes to calcium, you heard me say earlier that it's very much an issue of low calcium, really low calcium, okay? So here we go. I told you that I would give you a mnemonic for your calcium. Now, you're going to take all of your notes that I'm giving you right now, and you're going to write them at the bottom of the page. So, if you look at these notes, you can see it says cats. The C, Chavastex and Clonus. I told you I'd tell you about Clonus in a minute, so hold on. Now, you're not even going to check for Clonus unless your patient has brisk DTRs, because there is no Clonus if there is no brisk DTRs. So if you check my reflexes and they're totally normal, then you kind of look silly checking for Clonus, like for real, you look silly. Okay, stop it. Okay, but once you get brisk DTRs on the patient, and I just hope you remember what that means. Let me refresh your memory. Brisk DTRs means seizures. Remember that? It's a neuro issue, right? So every time a patient has brisk DTRs, you're going to know, oh God, there might be a seizure in there somewhere. Okay, so stay with your girl because I'm going there. So we have Chavastex, and then if we do the A, we know that calcium is needed for proper heart activity, cardiac activity. So this would be an arrhythmia. Dysrhythmias, arrhythmia, same thing, but we use an A. Arrhythmias, paresthesias. You know, I like to rhyme. Come on, stay with the Jay-Z and me. So arrhythmias, paresthesias. Boom, you got this. Now what the hell is paresthesias? Well, it means numbness and tingling, okay? And that numbness and tingling can be in fingers or toes or whatever. Now, if you keep rolling with your girl, T for tetany and trousseaux. S for seizures, spasms, and stridor. Stridor is very important when it comes to the surgical patient who had their thyroid or their parathyroids removed. Now, if you were in class, I would tell you to put your hand on your parathyroids, and for whatever reason, y'all be all up in the bra and the underwear and the back and the sags, and this is right here, so stop it, okay? You gotta know your anatomy or it's gonna be a problem. So seizures, spasms, stridor. There's all your S's. Now, when we look at these big deal signs and symptoms, you know that you have a handout that has the signs and symptoms. You wrote the cat stuff right in here. You did that. You were a good boy or girl and you did that. And when you turn the page, there we go with all of the different things that you have to know. Okay? Now, so if we look at the picture, we see Shavasticks. I teach you. CH for Shavasticks, CH for cheek. In other words, the patient with the positive Shavasticks, if you look at the picture, oh, and by the way, I've seen that picture a lot of different places. I'm just saying, I've seen it before. Okay. If you look at Shavasticks, the nurse taps in front of the ear. She taps the cheek. CH for cheek, CH for Shavasticks. She taps the cheek and she gets this patient complaining of their mouth and their face twitching. If they complain at all, they may just do it if they're kind of out of it. And that is a surefire sign that the calcium is very low. Hypocalcemia. Don't confuse it with hypokalemia, okay? Now, check this out. Trousseau's, on the other hand, is confusing on this handout. But I keep the handout because I give you more information so you can handle the business very well. So here we go. Trousseau's is actually both of these pictures, even though one of them says tetany. I'm going to give you the notes for tetany, but this is actually Trousseau's. Both of these pictures are showing Trousseau's. Oh, and let me show you on this page what you got to know. You got to know that very long word. Where the hell is it? Sphygmomanometer. You've got to know this long word. Metacarpophalangeal joints. I know, don't shoot the messenger. I know it's a pain in your butt, but you got to know it. And so let me tell you what's going on with Trousseau's. And you really got to write this down because you can't be dingy. You really got to know your stuff. Let me tell you what exactly happened with the person with the Trousseau's. What happens with Trousseau's is the nurse puts the blood pressure cuff on the patient. She turns that knob and locks it in. She pumps it up. That's called inflate. Pump it up. And, well, I lied, didn't I? No, I didn't lie. I might have lied. Yeah, I did lie. Okay, so here we go again. Put the blood pressure cuff on, pump it up first, then, you know, turn the little knob or whatever to lock it in. When you lock it in, yeah, I did that right, turn the knob, so whatever. When you lock it in, watch this. The thumb is going to flex, the fingers are going to look like the claw, and they're going to go right across the thumb like that. The exact thing in the picture is what you're going to get, and your patient's going to kind of be stuck just like that. That is a low calcium. That is a positive Trousseau sign. That is a very bad thing and a low calcium. Okay, so that's what that is. Now, tetany is completely different. So I'm going to have to write it out because I don't want you to, you know, look for me in the street and try to shoot me with darts because it's such a big deal that you're going to get lost if you don't stay with your girl. It is a patient with tetany is going to have a laryngeal, pharyngeal, bronchial spasms. Wow. Now that is airway. That's an airway you care about. Laryngeal, pharyngeal, bronchial spasms. My God, remember? Spasms. Tetany. Airway. That's why tetany is the most important one. It's airway. And in this case, airway matters. Okay? Now, you need to write something else because you rarely will remember it if you don't. This is one of the few times that your patient gets a bradycardia or heart block. In your mind, for this purpose, it's the same thing. So a bradycardia or heart block, same thing, different day in your mind, okay? So the heart rate is actually going to be low with this patient, all right? Now, so tetany has to do with the laryngeal, pharyngeal, bronchial spasms. It has to do with the bradycardia. It has to do, here's your spasms, and then all you need is paresthesia of the fingers and the toes, so tingling, numbness and tingling of the fingers and the toes, okay? Now, what do we do to treat this? Well, common sense. If the calcium is low, hello, let's treat it with calcium gluconate, seizure precautions, vitamin D, because that you cannot absorb calcium without vitamin D, and that might just help, and then muscle relaxers. So when my patient's vitamin D is low, it means that their calcium is low. What do they get? They get numbness and tingling. They get Charlie horses, spasms, right? It's not that low, but it's low. And that's kind of important because most of the calcium, and you've got to really know this, most of the low calcium patients, it has nothing to do with diet. Write that down. Hypocalcemia has nothing to do with diet. The number one and number two people that you're going to find this in are patients who have had their thyroid removed or their parathyroid removed. Less frequently is the alcoholic or the patient with a vitamin D, a severe vitamin D deficiency. Now, the muscle relaxers will relax all this. Here's the causes: thyroid, hypoparathyroid. So this should say thyroid surgery, right? Because you just had it removed. And this says hypoparathyroid or low thyroid, parathyroid. Let me just remind you in case you get confused, because this is at the area where you cannot be confused. Okay, let me show you. Thyroid is not the same thing as parathyroid. However, if you have a hypoparathyroid, it equals hypocalcemia. That we know you want to remember. Hypoparathyroid, hypocalcemia. Now, let me explain. So I was scheduled for thyroid surgery on September 16th, I think it was 2016. 2 days before my surgery, I freaked the hell out because I know that you can lose your voice permanently during the surgery, and I thought about how I'll never be able to teach again, so I freaked out, right? It's just what you do. You're a nurse, you know too much. So I decided against it. I decided that I would do radiation instead. But let's just talk about what if I had had my thyroid out. Here we go. If I get my thyroid out, the incision will be right here. The tips of my 4 fingers represent the size of a parathyroid glands, 4 of them. The parathyroid glands sit securely and very attached to my thyroid on the side. Para means side. It sits just like that. So if they take my thyroid out, they can accidentally take some of my parathyroids with it. If they do, you have to remember that calcium and the opposite, phosphorus, are controlled by the parathyroid, not the thyroid. The parathyroid, right? It's controlled by the parathyroid. So if you take my thyroid out and you took by accident some parathyroids with it, then you took the calcium with it, and your calcium will be low. The problem is your calcium's not going to be low until you get home, you know, like 72 hours later, because thyroid surgery patients go home that day or the next day. And if you go home that day or the next day, a low calcium is not going to be something that we're really worried about that day. But when you're at home, if your patient complains of their mouth or their face tingling, this is a medical emergency. That's what the hell it is. It's a medical emergency. It's horrible. You got it? Okay, because I've seen it somewhere. Okay, now low calcium? I told you. Alcoholics, somebody taking hydrochlorothiazide diuretics or any diuretic, I told you this can make it very low. The tumor lysis syndrome, and the reason for the calcium being low in tumor lysis syndrome has nothing to do with the calcium. You must remember what I taught you a while ago. I taught you if you have a word with lysis, it means a destruction. It means a destruction of cells. Inside of every cell is potassium, but I also told you that inside every cell is phosphorus. Tumor lysis syndrome was a chemotherapy complication, and so the K was high and the phosphorus was high, and that automatically made, with the phosphorus being high, since they're divorced, it made the calcium low. Okay, all right. Now, I'm going to erase this because we only have one other thing to do with this electrolyte business, if you will. Okay? Oh, by the way, don't forget to write it down. The low calcium patient has a very good idea would be to give them high phosphorus foods. Remember that? Okay. The other thing I don't think you're that good at, because I know I wasn't, is the issue of calcium in the diet. Shall we have a little fun with calcium in the diet? You and me, just you and me, do this. Here we go. High calcium foods. Let's get that off our chest, right? High calcium foods. Now, where are you going to write that? You're going to write that on the page before this one. So go backwards to find your little calcium phosphorus page, and let's write our high calcium foods. First of all, we know green leafies, right? What kind of green leafies? The three most popular ones on anybody's test: kale, collards, and broccoli. Of course, you already knew dairy. I'll put it up here just to humor you, but it's not on any test. You probably did not know the disgusting tofu. We're going to write this down because we have to pass the test, because nobody in their right mind would eat it. We're going to also include almonds, almond milk, almonds. Very good way to get calcium. My favorite, because I'm not a dairy girl. Sardines. Mackerel. Y'all don't know nothing about that because you probably ain't poor as I was growing up, okay? We used to eat sandwiches with this shit, okay? So mackerel, and then you have to remember when it comes to calcium, got all of this, the dairy is not just milk, but it's also cheese, okay? So, boom. But the goal is to make sure the patient has adequate levels of vitamin D, because if you don't, you won't absorb the calcium. You cannot absorb calcium without vitamin D. If I give you calcium or vitamin D, if I supplement these, then you are going to need to take a chewable. A chewable calcium is the best way to get your calcium levels up. We know that the patient with a low calcium, if it is related to something else, like aging, osteoporosis, we know that a low calcium is going to put the patient at risk for fractures, hip fractures, and something called CHELLYS fractures. This is fractures of the wrist. Okay, your hip fracture, your fractures of the wrist, low calcium in the body related to aging, osteoporosis, is going to cause the patient hip fractures and fractures of the wrist. If we give this patient supplemental calcium, the best way to give it is chewable. That's the best way. You could give it chewables. They're really actually kind of good. They could even just take Tums, that's some calcium, and that always helps. You cannot take it with coffee or tea or any of that. So it's a really good thing to have, okay? Now, who else is low in their calcium? Here we go. Renal failure. Why are they low in their calcium? Because their phosphorus is so high, and the two go together, but the calcium is low because the kidneys cannot metabolize vitamin D. You cannot separate calcium from vitamin D. They have to go together. So with kidney failure, you don't have enough vitamin D, so you don't have enough calcium. And those are patients who would benefit from these supplements, okay? All right, so I think you understand this pretty well. Let me just make sure I gave you everything I needed to give you. Oh, for the patient with a low calcium, because they're at risk for fractures, they are under falls precautions. Okay, so you might want to write that down. Okay, now, so I think I covered that pretty well. Let me do a couple of easy reminders, and then we'll have nothing but magnesium left and some information about fluids. Okay, let me do a couple of little reminders about calcium. Here we go. Hypoparathyroid equals low calcium. Okay. Hyperparathyroid equals high calcium. High calcium is rare, but you would probably experience this: kidney stones, constipation, which is the #1 side effect of taking calcium over the counter as well, and then polyuria, because you are trying to get rid of the calcium by peeing it out. So the high calcium person, they would have these problems right here, and if that is true, then we know what we could do to treat it. Of course, we're going to hydrate, because I told you when electrolytes are too high, to hydrate them. We're going to make sure we throw an EKG on them, because the calcium can cause heart block or bradycardias. I told you that a loop diuretic or a thiazide diuretic will decrease the calcium. That's what we were doing anyway with any high electrolytes. We know that we might need dialysis if it's severe, because again, that's what I've been saying all day. And then we're going to need something weird. It's called chelation therapy. Chelation therapy will get rid of the calcium as well. Now, there is one thing I like to give you as a nice, I would say, treat, if you will, for a high calcium patient. Watch this, and then we're going to be done for today. Hydrate, ambulate, medicate, radiate, and this is for the high calcium condition of multiple myeloma, which is a cancer. Oma is tumor. And when I hydrate, I get rid of the calcium. When I ambulate like this, every step I take takes the calcium out of my blood and puts it into my bone. So ambulation is critical. medicate is calcitonin, and that's huge because it's going to lower the calcium. And the last one, because this, oh, and the other medication for that patient is chemo. I have an uncle with this. Last one is radiation because it's a cancer. Just thought I'd share that with you because you care. Peace out. See you in a while because I'm doing part 2 tomorrow. Bye-bye. All right, I'm back. Sounds kind of bad, doesn't it? I know. Okay, well, I'm back. So Dr. Shelley, me, is going to get you through this electrolyte and fluid lecture. There are quite a few parts to this lecture. As you know, we have done part 1, and let me just remind you of a couple things. For this next section, you're going to definitely need your acid-base balance, handout, imbalance, I should say. Now you will actually need your Oh My God packet. If you are a nursing student and you don't have the OMG or Oh My God packet, it's okay. That's for my NCLEX review students, okay? Many of you have purchased the CNR Pink Packet Supplement, and I just want to go over some of the things that the Pink Packet Supplement has in it. It has your test-taking strategies. It has your prioritization and delegation. Inside of here are all your infectious disease precautions. There is the procedures and your EKGs with the answers. You have your pharmacology, you know that's big, and you have your management of care, your ethical, legal issues that nurses have to know. And this is for the student who is about to take their NCLEX review. It is $49. I thought I would remind you about that. Now, if you are a student and you do have your book with you, you're going to need to turn to the Miss Piggy section of the beginning, Oh My God section of the book, and that is going to look just like this, okay? If you are working with your OMG packet, as you know, that book has the OMG in the very beginning, and for you, all you need to do is simply turn to page 8 with Miss Piggy. Now, Miss Piggy is wonderful. I learned it at Ursuline, and it was just the most fabulous way to learn electrolytes. So I'm going to come in closer and show you just how easy learning your electrolytes can be. Number 1, Miss Piggy is an entire sentence, but you have to be very careful. You have to see how Miss Piggy and Kermit came home on cloud 9 has an ampersand sign. The number 9 or the word 9 tells you there are 9 spaces. The ampersand has to go into space 3 or you're going to screw this up. And so as you go through this list, they are the very first letter of the words in the sentence. So the first letter of the first word is an M. That's your magnesium. The first letter of the second word is P. This is your phosphorus. The ampersand is number 3. The K in Kermit is potassium. The CA in Came is, of course, your calcium. The HO in home is your bicarb, okay? And then, of course, you see the O for oxygen. And this is the easiest one because everybody came in here from kindergarten knowing 95 to 100 for oxygen. And then, of course, you have the Cl for your chloride, which no one ever cares about. And you see the word 9 and the N in the word 9. So the N is sodium, Na, sodium. But more importantly, it tells you you have 9 entries. Now, this is the best part. Roll with your girl. You know I like to sing and dance and act a fool, so here we go. 1.5, 2.5, 3.5, and 8. Then I want to tell you a little something about the bicarb, because I don't say 22 to 28. I say 25 minus 3 or plus 3. Watch this. For the bicarb, if you say 25 plus or minus 3, 25 plus 3 is definitely 28. 25 minus 3 is 22. Now, so the bicarb is 25. So I'm going to start over and let you see how that flows, okay? Because we're doing the Jay-Z thing. 1.5, 2.5, 3.5, and 8. 25, 95, 105, and 35. That's kind of how you got to flow. The numbers get bigger. Do not stress your Jerry curl over the last number. What I'm doing is giving you a ballpark, right? Because too many students are extremists. They go all into the points and all this stuff. No. I'm giving you a rough way to kind of estimate this stuff. So 1.5, 2.5, 3.5, and 8. 25, 95, 105, 135. That's it, guys. You will love me. This works really well. Now, I want to point out a couple more things. This whole section is based on, acid, base, or electrolytes. And I gave you tips. Here we go, because we're going to talk about hypomagnesemia in a minute. If you look, I gave you the same tips I've been saying this whole time. Calcium is the same thing as magnesium. They are both low with alcoholics. If the magnesium is low, the dig is high. Now you heard that before because you heard the same thing with potassium. Let me give you more love. The P for phosphorus, 2.5, is high with chronic kidney disease, CKD, AKI, which is acute kidney injury, high phosphorus. Phosphorus is the opposite of calcium. You've heard me say that before. Go a little bit further, deeper into the packet. You'll see the potassium. Watch the EKG, the GI, and the kidneys. There we go again. If low, dig high. And we're talking digoxin. If you'll remember, I told you a digoxin level of 2 or more is toxic. How will you know? Vomiting, green and yellow halos, bradycardia. You remember. Calcium. There we go. Tetany, Chavostics, Trousseaus if low. Bicarb. If all gases are abnormal, you're going to have to look at your bicarb to see if there's partial compensation. That's a whole nother lecture, let me tell you. When you're looking at the oxygen, I put the emergencies from the respiratory song right in there. I put the SaO2/SpO2 less than 90. 95 to 100 is normal, but once you get below 90, we have a medical emergency. The chloride, no one ever cares. You see, I didn't write nothing. The sodium, OMG. Look at it. Hyponatremia, which we've discussed. SiADH, which we talked about. If sodium low, K high. That was a quick review. I hope you're paying attention. You didn't leave the room, did you? Because you really screwed that up. All right. Now, we're going to go into the acid-base imbalance packet now. It's going to be a little tricky on your part because we don't have a handout for magnesium. So what you're going to need to do is go all the way back to your calcium phosphorus page and remind yourself that calcium is the same as magnesium. So everything that a low calcium has, a low magnesium has. That's a good thing to remember because basically the symptoms are the same. Now you may remember the mnemonic of CATS. At least I hope you do. I really hope you do. Do you remember CATS? CATS was our mnemonic for a low calcium. So here we go, because once we do this little part here, we're finished with our electrolytes, and then we can go on to something more exciting. Sound good? All right, here we go. Let's rock it. Hypomagnesemia. We've already looked at our Miss Piggy, so we're done with that. The signs and symptoms are exactly the same. You want to remember just what I just said on the Miss Piggy. I said the calcium is the same as magnesium. I said check the potassium if the magnesium's low. And I want you to remember a low magnesium equals a high digoxin. All right, so we did that. Why would someone's magnesium levels be low? Well, you got to go back to the gut and the butt and remember that if a patient has a GI disorder or they're an alcoholic, their magnesium will be pretty low. By GI disorder, I'm thinking celiac disease. I'm thinking a patient with an ileostomy that is really not doing too well, because remember, an ileostomy is basically diarrhea in the bag. I'm thinking about the bariatric or gastric bypass surgical patient. I'm thinking about the patient that has any kind of losses of fluid from the GI system. I am also thinking about the patient who might be on diuretics, and especially thiazide diuretics, because they lower the calcium, and wherever the calcium is, the magnesium is. But then I'm also thinking about hypoparathyroid, because again, hypoparathyroid, hypocalcemia. Calcium and magnesium are the same. So you know the calcium's low with hypomagnesium or hypoparathyroid, and so you could quite likely have a low magnesium. Now, the complications of having a low magnesium, just consider that you could have a paralytic ileus, where your whole entire bowel is paralyzed, paralytic, paralyzed. So you could have a paralytic ileus. You could have dysphagia, where you can't even swallow, right? So this is horrible. How do we treat it? And by the way, it's not that common, except for, like I said, the alcoholic. These things I don't see that much. I do see people with a low magnesium, but I do not see the complications that much. The complication that I see more than anything, and I really want you to know it because it is kind of common, like I've seen it somewhere before, is torsades. You remember, we talked about this real briefly. So here we go. The nursing care of the hypomagnesium patient requires an EKG because they're at risk for torsades, which is just a dysrhythmia. If you are in critical care, you will need to know it. If you're doing adult med surg, you'll be fine just with knowing the EKG gives you a dysrhythmia. Lastly, how do I treat this patient? I treat them with magnesium sulfate and sometimes calcium, okay? Now, we need to stop any diuretics that the patient would have and watch our fluids. So all of this just makes perfect sense. The last thing I want to do, because some of you really do have to know what torsades looks like, and give me a minute. I always want you to know what torsades looks like because it is just so dang common. And torsades, I did show you this before, look suspiciously like VTAC. Really hone in on that, take a big old peek at that. They are different. Torsades and VTAC are different, but they are both life-threatening strips. And often the patient with the torsades is either an alcoholic or they also have a low digoxin level. So again, digits toxic at 2. How do you know? Vomiting, green and yellow halos, visual disturbances, bradycardia, you got it. Hypomagnesium, you know what it is. It's the same as calcium. If you think about that, that's going to be easy. Miss Piggy, 1.5, 2.5, 3.5, and 8. 25, 95, 105, 135. Y'all got that? Ooh, that sounds good. I need a beat. Can I get a beat? I'm sorry. Oh, I'm gonna let y'all go on because I get so wrapped up. Okay? Deuces.